Hello, I am Bizrah, consultant ENT facial plastic surgeon. I published my textbook on rhinoplasty, facial plastic surgery in 2002. The book has more than 500 pages and 1,000 illustrations. The textbook was forwarded by the presidents of the American and European Academies of Facial Plastic Surgery and was distributed worldwide. I hope you find these videos are very interesting. It's designed mainly for surgeons, plastic surgeons, and ENT and facial plastic surgeons. It's professional and educational. It presents my approach, my school, the Bizrah School of Rhinoplasty. You are most welcome, and I hope you find it very interesting. I'm going now to explain how I do the local anesthesia, my block. The patient is already under sedation. So first of all, we start injection on near our osteotomy line. So this is the first line to give the local. And you see, it goes there and aspirate first. And this is your first line of local. The second one along this line. So you go like this, and again to the nasal. Aspirate and give this one. You see, the patient is under sedation, and this now again do the same on this side. This is the line here. Your intercartilage incision around the dorsum, and again to the nasal, and go out and do the injection. And then this line, your osteotomy line. Again, so it goes there, aspirate and do your case. All right. Now we go in between the two, in the middle of the dome, between the two lateral crosses, in the middle of the dome, and down all the way through to the bone. Down all the way through to, see, I'm hitting the bone now. Aspirate and go slightly up and inject the columella. You see, the columella is injected by, and then the interdermal area. Okay, so that's fine. And now we inject the base, the nail, again hit the bone, aspirate, and a little bit. Other side, again, hit the bone, aspirate, and inject. So now we have done, give me a little bit more. We have done full block around the nose. So we do also small block at the infraorbital nerve. This is the place of the infraorbital nerve in this side. And this is the infraorbital nerve foramen on this side. So again, we'll just go slightly and get to this foramen here. You see, I'm feeling the needle and just aspirate. You see, swollen, just do small blocks there. Again, on the other side, it goes there, and I'm feeling the needle now. Aspirate and do small blocks there. So that will give you very good local, and the patient will feel nothing and will give you very nice filled. And now we will put nasal back. 2 nasal bags soaked with xylocaine gel and some adrenaline. Okay, this will give us very nice hemostasis on the mucosa of the nose. You see now, and we'll leave it now for 20 minutes. After 20 minutes, we'll start our procedure, and you will have, as you have seen all our videos, very nice, clear, filled with no much bleeding at all. You'll be able to see, and this will save you doing GA and the hypotensive technique. Thank you. Now our consultant anesthetist, Dr. Manal, will explain to you about her sedation. What she is using to sedate the patient. You just see the patient very nice, very calm, and nicely sedated.
Hi, good afternoon. I'm Dr. Manal. This is the most modern technique of giving anesthesia. This technique called target controlled anesthesia. So we can give the patient a steady state of analgesia programmed by this continuous infusion pump. These pumps are programmed pre-operatively by me and according to the patient's sex and age and weight. So this equipment is giving continuous infusion and providing a heavy state of anesthesia, enabling us to have a conscious patient but under a heavy level of sedation, deep sedation. And this sedation usually is not by this continuous infusion, but also supported by giving titrated doses of narcotic and anxiolytic. So the patient, we will have the patient conscious, but sedated and under narcotization. So our patient here, we can have this patient under safe, monitored, smooth anesthesia. Everything here is monitored. Her vital signs, blood pressure and pulse. And this mode of anesthesia, we can avoid the side effects of general anesthesia, and many side effects we can avoid it, and also we can speed up the early recovers from the medicine, and we can have the speed up discharge for discharging the patient early from the hospital. So no need to stay here. Maybe if the surgeon asks for 1 day, it will be maximum. And everything will be under close monitor for through controlled blood pressure, very light level of deliberate hypotension, and everything is monitored here. And when the surgeon finish, we will wake up the patient through maybe 2-3 minutes like this, and we will transfer the patient to recovery, and there we will keep him for like 20 minutes under closed monitor for his hemodynamics and vital signs, and after this we will discharge the patient to the ward, and that's it. It's very safe model of anesthesia, and the patient will be very happy because he can go away at the same day to his house, and everything will be under control. Thank you.